I'm extremely excited to present to you social network interventions in medicine. This is a topic I've just been very much placed as a goal for our entire program is to start developing these interventions, and I'd love to get feedback as we proceed through these ideas. This is my research support, mostly through NIH and financial disclosures. We have spun out a startup called ECAS for pre-hospital delay, but that is unrelated to the topics that we're discussing today. So the objectives today, in about 30 minutes, is to understand the personal network paradigm and methods, and then explore ways to leverage the social network to improve outcomes in so-called social network interventions. So I'd like to start. I love presenting to the United Kingdom because most of my inspiration comes from many of the thinkers from the United Kingdom. So William Shakespeare here in 1600s stated that men take diseases one of another, therefore let men take heed of their company. And so even he was a network scientist in certain regards and really understood the relational aspect of illness. In fact, there's someone who predated him, Aristotle, was also very interested in relational elements of humankind. Aristotle says humans are the zone politikon, the political animal at home in the dense, complicated social web of the polis, the city, and ill-equipped to thrive in isolation. We are intrinsically interdependent and vulnerable. We need each other, and this need is not a defect or a failing. It's a central genius and beauty of our species. So these are, very old ideas that I've actually sort of really absorbed and tried to apply to the medical aspects of illness. And so in medicine, it turns out networks are mostly invisible. And so one of our first tasks was to make the invisible visible. It's a phrase from Foucault there. Um, Personal networks are these web of relationships that are abounding around the patient in intricate structures that contain strong and weak ties, not just to the patient, but to each other. And this is a topography that one can understand and actually makes a difference in the patient's trajectory and their access to healthcare, and many, many habits and self-management rituals really depend upon what structure they're within. And then it turns out organizations are also within networks that are mostly invisible. Here are hospitals in California that are interconnected by the patients that they share when a patient moves from one hospital to the next. This isn't just transfers, this is actually human movement of any sort. So when a patient decides to just go to another healthcare facility, a tie is brought to this picture. And one can see that even without us trying to deliberately place the geography of California, one can see clusters that actually reflect the geography without us trying. So this is also invisible ties made visible. We're going to focus on the personal networks today. So in 2016, we wrote this sort of theoretical paper that that indicated to the community that in specifically neurology, whereas the practice of medicine that I practice, every patient that I see is embedded in some sort of social network of interpersonal connections that influence health outcomes. And indeed, neurologists, we routinely engage with the patient's family, friends, due to the nature of the illness and its social sequelae. And we wrote, therefore, a theoretical primer on what is personal networks, how do we define it, and then how do we measure it. And this is where this figure came from, which I now use all the time as sort of the theoretical conceptual model that we are trying to apply to patient healthcare. So the definition one definition I like is personal networks describe the relations of a set of individuals around a focal individual. It still privileges patient in the middle. There are other methods that look at the sociocentric methods that look at all the nodes as equal. This still looks at the egocentric perspective. It still places the patient in the middle. That's sort of a way of the method works. So that's why we do that. And here's a description of the method. So another phrase I use is we're mapping the social connectome. And to do that, we ask questions to generate names of the patient's social world. So the first question we ask is, who do you discuss personal matters with on a regular basis? And this we suggest is the advice network, core discussion network. Secondly, we ask, who do you socialize with a regular basis, such as eating dinner together or having coffee or even traveling together? And this produces a second ring of names that are called the social ring. And then finally, especially in our context of health, we ask, who do you turn to for support in the case of a health crisis? And that may generate other names, or it may generate the same names. And then the task of the survey is actually to eliminate redundant names and to have a single list of individuals that the patient either has nominated in the advice, social, or support ring. And we collapse these, and this becomes the social ecosystem around the patient. And then we go about quantifying the actual ties. So we ask, do you feel especially close to the person in the corner there, Albert? Or do you feel not so close to that person? So there's a strong and a weak perceptual, from the perception of the patient, a strong and weak tie that's produced. And then we go another level, which is, okay, patient Mr. Jones, can you please describe the relationship between Frank and Mary over here? Are they especially close, not especially close, or are they strangers to each other? And by strangers, we mean they wouldn't recognize each other if they passed each other on the street. And so again, based on the perception of the ego, we get these axillary ties, which then create an entire network. And this network can produce metrics such as size. So then the network size in this case is 4. And then density is another fairly simple measure of the connectivity of the network. It's the number of ties that are present divided by all ties that are possible. So in this little network, there are about 6 ties present and about 10 ties that are possible. And so it's 60% dense, or 0.6. And then we can have other network measures that are derived. It's that are good or bad, who's a male or female, what are the characteristics, what are the education patterns of these people. So we really get a beautiful understanding of the milieu of the environment around the patient, both structurally and compositionally. And then we believe that this, both theoretically and now empirically, we've demonstrated that this affects health. It's linked to health. And the way that we kind of think about this is 3 major processes. One is the support. And so there are certain aspects of the network, certain subgroups of the network that are particularly important for the support of the patient, from instrumental support to emotional support, all these different types of psychological support. That are available is provided by certain, especially strong-tied individuals. But then another aspect of the network function or resource is information. And it turns out here, this is less well known, that different components of the network provide different information to the patient. So there's group on the left provides one type of information, group on the right provides another type of information. And this is where weak ties really are important, because The weak ties provide novel information that is not already circulating in your network. And then finally, health habits. So I told you that we map the compositional aspects, the health traits of these individuals. Well, those traits, we believe, percolate within the network in terms of setting the standards or setting the cultural pre-inclinations of what the patient would choose if they had to choose what they eat, or if they had to choose if they were going to smoke, or they've had to choose if they were going to exercise. I think a lot of it is dependent on what their network members are used to and doing, they do together, frankly. So this, if you can remember this idea of support health habits information, this will come up when we try to harness the network in terms of interventions. Okay, so ties are channels of influence. So here's the real life networks that we create and we now put into the medical charts of certain patients when they see me in clinic. Um, the red lines here are strong ties. The blue dotted lines are considered weak ties. And you can really start to diagnose these network pictures. Here we have a core network, David, Victoria, Richard, who are all intimately connected together. And then you have this sort of wider group of what we call the outer circle of individuals who are variably tied to each other and weakly tied to mostly the ego. But overall, this is a very strong and healthy network. It includes 10 people. It's 70.75 dense. It has 60% family and 10% who do not exercise regularly. So only 10% of people are sort of bad habit percolators in the network. Okay, compare this same person. Imagine the same patient in your office, same age, same demographics, but this is their network structure. Here, the patient is tied to three strong tied individuals who are actually variably connected to each other in terms of strong versus weak. Then they has a weak tie to another person. And if this person had a large ischemic stroke or something debilitating, I think you can imagine that the resources available for that patient are less in terms of very practical things like who's going to take me to rehabilitation appointments or am I going to eat a healthy diet? How do I make sure I take my medicines? And so in this network, the resources create a different type of environment that affects the patient's trajectory, we believe. So the patient size, the number of people here is 4. The density is 100%, which by the way is not always good. In some cases, it's good if everyone knows each other. In other cases, for information purposes, it's not good. It's 100% family, and 75% do not exercise regularly. And so I would just ask you to imagine, these invisible ties of these patients and how they influence person one versus person two in terms of their trajectories. You can apply this to any disease. And so now, as Anna was mentioning, we've actually scaled this and open sourced it and enabled other research groups to take advantage of these tools that we created. And so this is the PersNet tool, and one can download the tool on RedCap and then map their networks, and you can actually adjust and sort of tailor the questions to your illness. And then hopefully you can find modifiable elements of the social environment to then create interventions for that's our dream. Okay. And this is a example of what we're able to do. I find this so beautiful in its rich diversity and the tapestry of network design here. This is 1,488 networks from a traumatic brain injury cohort, and it just displays this beautiful array of different images that I think are very impressive in their in what they show. Okay. So I'm just going to end this sort of introduction to personal networks with a description of one of our papers and then a patient story. So one of my first tasks was to actually map over 6 months the social network changes that happen after ischemic stroke, and then to also understand how social network metrics measured at baseline would affect 3 and 6 month outcomes, which we measured using the NIH PROMIS score, which is a patient-reported outcome measure. And essentially, I'll just summarize because I want to get to the patient. What we found is a patient's network does shrink over the 6 months. You lose about 1.25 people as you had your stroke in 6 months. It also becomes denser and more family oriented. So this is recapitulating things that we've known in the social network studies of stroke survivors. But it's interesting. We were the first to show that the composition actually also becomes healthier. There's pruning of ties with people who smoke or do not exercise. So just naturally, without any intervention, people actually reduce their contact with people who smoke or who do not exercise, and the network actually becomes healthier. So that's a kind of inspirational, upbeat conclusion of the natural history of networks after stroke. We also found that the network size, the number of people, was related independently to 3 and 6 month physical function of the stroke survivor. And this is independent of their social demographics, their psychosocial, their depression, all the other elements. And so I call it the more hands on deck, the better, is what I tell my patients. And so anyway, that's the sort of natural history of networks and sort of our synopsis of how the method has empirical validation here. And here's a story. This is a 4 minute story I'd like to listen to. This is a man who has an exceptional personal network that it's just so many lessons that we can take from this. And if we could put that in a bottle and deliver it to other patients, this would be the ideal social network intervention. But let's listen to his story.
Hey, sir, how have you remained so resilient after your stroke?
Well, because I have faith in God and because of the support that I have with my family and friends and with the social media that I keep in contact with people who are like me and the people who are, far away that I wouldn't be able to see.
Can you give me some descriptions on how your social network has been so supportive?
Well, the fact is that I'm more aware of what's going on and I can keep up with things. And people, they tell me what's going on. And then they also tell me that they're, praying for me and are happy with my progress. And it's just general talk, of everything.
Yeah. Are you getting out of the house these days?
Yes.
What do you do at the house?
Well, I walk and then we go eat. Or like if I'm not like this Saturday, I'm going to be going on a little road trip, and we're going to go to Creekor Park and take just a walk through the park, and then when there's benches, sit down and just observe. If it rains, then we will find another alternative.
Sounds like a date.
Yeah, well, call it a date. Yeah, she's my best friend, and I've just known her forever. We went to college together, and her husband, and all that.
Good.
And but it's just with Fred. I have a friend named Janice that she's had several strokes, and she sends me a card about every month of encouragement, to say, and then she writes me a little note about how she progressed, and for me not to get discouraged if something doesn't quite well if you work at it. So like that. Then I have a friend up in New York that calls me about twice a week, and he's always encouraging me and watching the videos on or watching the Facebook to see what progress is going and so forth. But I have that's about it, I guess, you know.
If you had to give me a number on the people you talk to about personal issues, how many people would that be?
I only talk to my family, and I guess say 4 or 5, about 6 people that I really feel comfortable with, you know.
Yeah, talking to about personal
Yeah,
issues.
personal things.
And how about how many people do you socialize with, like go to dinner with and travel with?
Well, it depends. It's between anywhere from 4 to 6, maybe 8.
8 more people.
Yeah.
And how many people could you turn to for support if you needed it, if you needed some help? Who you could turn to?
No, I've got a really good support, you know, people. I mean, there's people that will come in and when there's a need, well, I could just about call on anybody.
Yeah. But are they different than the people you just mentioned, or are they
Well,
about the same?
They're about the same, except if I needed somebody outside my core group,
Yeah,
I could get them.
good.
There's people that are offering that, not my core group, that are offering when they see me at church, say, can we do anything to help you? Can we, you know, if you need help, let us know.
Yeah.
And I said, okay, thank you.
All right. Thank you so much. You're an inspiration to all patients.
Thank you.
All right. And so with that, I want to transition to intervention. So social network interventions, relatively new idea, difficult to execute. It is Thomas Valente wrote a science article about how to execute this, and he describes different methods of restructuring the network or of leveraging, harnessing the current network or creating new ties. It's all been very nice theoretically, but in applications have been few and far between. So we attempted to do something that was embedded in the clinical medicine circle, which is we created a social network intervention for stroke survivors called Teams BP. The enhancing of social networks aim to manage blood pressure after stroke. Um, and so we really underscored this team idea. And so our um, first of all, the problem statement is that the effectiveness of activating and harnessing supportive personal networks is uncertain. Despite being the largest risk factor for recurrent stroke, blood pressure control is suboptimal in up to 50% of patients after stroke. So that's what we wanted to change and see if we could in a pilot study. This is a small study. And again, here's the conceptual model with support being central. It turns out, blood pressure control really revolves around healthy diet, especially low salt, uh, exercise, and medication adherence, and then monitoring of blood pressure. So there's essentially 4 core elements to creating a good blood pressure trajectory. And we felt that instead of placing the onus and the entire job onto one person or one person and their caregiver, what if we could delegate the different tasks of optimal blood pressure management to the different parts of the network? And so Charles here will be the exercise guru. Everyone we hope will eat healthy because you eat together. Anna up there will be the blood pressure monitor. And yeah, and so that is our dream, is if the network could work as a team to help the patient achieve a goal of optimal blood pressure, which is a very we recruited 45 patients. So this was a pilot RCT. We compared a network intervention versus individual counseling for 3 months with the aim of lowering blood pressure after stroke. 45 hypertensive adults hospitalized with symptomatic and imaging confirmed ischemic stroke were our participants. And the primary outcome was absolute reduction in systolic blood pressure over 3 months in one group versus the other group. In the individual counseling arm, a study nurse met individually with each participant one-on-one on 3 monthly Zoom sessions, so once a month Zoom sessions for blood pressure teaching. In the social network arm, the same study nurse met with the participant and social network members on 3 monthly Zoom sessions, same frequency, for a team-based network intervention in which every person has a role and responsibilities along with the traditional blood pressure teaching. So that was the comparator. Here's the beautiful network diagrams of these 45 patients. Again, a beautiful diversity of network structure. And here is the trend of the results. So systolic blood pressure does go down more for the intervention compared to the control group. So this was promising trend. Unfortunately, it was not and this is the actual numbers. It was not statistically significant. There's a low sample size here, as well as heterogeneity in the outcomes. So this is a GEE model to determine that, yes, in the intervention versus the usual care, there's a 5-point difference in blood pressure, but this did not reach statistical significance across the two groups. We then did subgroups, including dividing people by network size, network constraint, age, sex, blood pressure at baseline, and the proportion of others in the network who have high blood pressure. The only significant one was constraint, which is this third one. It turns out people who are in a high constraint network, so those small, close-knit networks, those patients had a very positive response to the intervention compared to the patient who had already had a big network, did not respond as well, and that was statistically significant. So it suggests that there may be a select group of patients who we may target who have small constrained networks who really do get advantage from such a network intervention. So that's a cool, interesting finding. So there's lots of lessons learned here that I hope to propagate in the paper that we're just writing. There's a real cultural inclination in both your country and ours towards individualism and self-reliance in Western societies that pervades healthcare. Patients were initially very reluctant to engage network members, and we had to do a lot of coaching to get them to engage the network members that they just described in their maps. There was also a high degree of dropout and variable engagement in the network arm due to multiple reasons. So this included life being in chaos after stroke and actually low prioritization of blood pressure. They were focused on trying to rehabilitate and get back home, and blood pressure was not a high priority item. And so these are some of the hard lessons you learn by doing a trial. And here are the overall study conclusions. There was no significant overall effect of a network intervention on systolic blood pressure reduction in stroke survivors. Subgroup analyses did suggest that patients with constrained networks may benefit more from such interventions. And the results do highlight the potential for tailored social network interventions to address specific needs in stroke recovery. And then here's my overall conclusions. Social networks are ubiquitous and influential in medicine. They can be mapped, and I think we have a very nice method for mapping them that's ubiquitous now on REDCap. And it can be analyzed using established surveys on large health administrative data sets as well. The social networks also may be leveraged to improve behavioral therapies and quality of life. If you believe our conceptual model and our early empirical data, then you can see that this is a burgeoning area that really deserves merit, especially for lifestyle behavior modification illnesses. All right, and that's it. Anna, back to you.